First of all, thank you for inviting me. It's a very exciting time to be working in thyroid eye disease, which wasn't a few years ago.
Just click on it.
Okay.
Yeah. Just click anywhere. It'll go. Yeah.
Okay, so these are my disclosures. So I'm going to use the thyroid eye disease, or TED, in my talk, but the condition is known by many names. So I'm going to hinge my theme on Paul Gauguin, the 19th century French painter. So he was working as a stockbroker in Paris, and he wanted to find a new world. So he went all the way to Tahiti, and he painted this iconic painting, which I shall use as a theme for this talk. Where do we come from? Where are we now? And where are we going? And then I'm going to also reference one of my favorite art collectors, Team Lab. They have major installations in many cities of the world. So nowadays you can walk off a busy street in an urban metropolis and go to a different world. So it's a little bit like a paradigm that's been kind of influencing thyroid eye, in the sense that therapy seems very, very far away. You know, Tahiti is 24 hours by flight, and suddenly it's right on our doorstep. So, but we have to kind of revisit where we came from in the first place. So the condition was first described by Avicenna, the 9th century Persian physician, and he's very aptly just linked the goiter and the eye disease. And he could almost be an ophthalmologist. The preciseness, he described corneal edema, chemosis, and the extraocular motility disturbance and the terrible double vision. Then it moves to Robert James Graves, the Irish surgeon, who gave his name to the thyroid condition. But the more modern father of thyroid disease is the German physician Karl Adolf von Basedow, and he described Madame G sleeping with her eyes open, associated with her goiter. And again, you know, it's very apt. No discussion of the history of thyroid eye disease was complete without a reference to the Blundell's curve. This was described by Francis Felix Rundle, who's an Australian surgeon working in Sydney. And so in his 1945 publication, he described the exophthalmometry measurements, the degree of proptosis measurements of 2 patients over 30 months. And from that, somehow it extrapolates to this ideal and theoretical curve of thyroid eye disease, that there's a dynamic phase, a static phase, but just bear in mind it was based on 2 patients. But for many, many years, we used this as a paradigm to describe the disease. So where are we now? So one of my patients kindly gave me this photo. So you can see on the photo on the left-hand side, she's at the beginning of the disease. The eyelid had retracted a little bit, but within a year, she had transformed to the appearance on the right. And it's very poignantly echoed by this this phrase from another patient in the Rarasinger and Kahali textbook on thyroid eye. From a beautiful young woman, I changed into a creep who stared at people pop-eyed. Children backed away, adults nudged one another. Having a squint made me quit my hobbies and make mistakes at work. And this hasn't changed. There was a workshop Kareem and my colleagues ran with a group of our patients in 2019. In the word cloud, you can see the words most commonly associated is pain, ugly appearance, depression. So this again is validated by, more systematically by Kathleen Pontel's paper in 2009, when they looked at patients attending an MVT clinic in Germany, and it reflects the huge psychosocial economic cost for both the patients, their families, and society at large. And even more starkly, by this Danish population study, showing that TED patients are 3 times more likely to die from suicide compared to the general population, and twice as likely to kill themselves compared to patients with raised hypothyroidism without the eye disease. So what have we tried to do about it? So in 2009, all the stakeholders working in TED gathered together in Amsterdam and tried to create an initiative, the Amsterdam Declaration, to improve outcomes. And one of the major organizations that has been very pivotal in trying to improve outcomes is the European Group on Graves' Oculopathy, which I'm very proud to say Imperial is one of the centres, across, mainly Europe, and there's a centre in Singapore as well. And over the years, they've been responsible for many of the landmark publications on the condition. In 2007, to describe the features of sight-threatening disease. 2011, the NEJM article about selenium being beneficial in mild TED. The 12-week course of intravenous methylprednisolone that's in all our guidelines that we use, described by George Kahali. The fact that the MDT improves the diagnosis and the accuracy and speed of the diagnosis of the disease. The mingle targeting efficacy of mycophenolate as a second-line agent. And over the past 13 years, three guidelines which we all follow. And most of all, one of the greatest contributions is the GOAL-QOL, which is the quality of life questionnaire. It's 10 official translations actually rising, it's probably 20 by now. We're really accurately trying to translate this. So the UK initiative has been spearheaded very much by a group society led by Colin Diane. And this is the TMED, and the aim is to try to diagnose, screen, alert all patients, and prevent the onset of the condition, and actually ensure that all patients with moderate to severe disease have access to a multidisciplinary clinic. And on this, we ran a national survey from the eye side as well to see what the provisions are. We came up with guidelines which have been endorsed by all the stakeholder organisations, including both oral colleges. So the main thing with any condition is that we need to make sure that we make the correct diagnosis. We're trying to modify risk of developing the condition. So to misquote Jane Austen, thyroid eye disease is the leading cause of proptosis and the leading orbital cause of double vision. And bearing in mind that if you look closely enough, probably 1 in 2 of your Graves patients will have some subtle eye signs. But they not all, some of them do not. They can have just have the eye disease, often antibody positive, TSH receptor antibody positive, and they may be euthyroid. So that is those are the tricky ones. But there are many other causes of inflammation of the orbital muscles. And so when patients are atypical, when they don't have a straightforward diagnosis of Graves or Hashimoto's, we need to consider all these other causes. They can be idiopathic, autoimmune, infectious, drug-induced, or paraneoplastic. A classical example is that these 6 patients of mine all had a history of thyroid dysfunction and all sent to me for various for query thyroid eye disease. The lady on the top left actually had a neoplastic syndrome of metastatic breast cancer. The one in the middle had 2 pathologies. She had thyroid eye, and she had an orbital vascular malformation that bled and gave her the gross proptosis, and we had to treat her decompression. The one on the right had myasthenia gravis, as well as thyroid eye. And there's about 1.7% of this overlap. The one in the bottom left has thyroid resistance syndrome and actually had quite significant moderate to severe disease that required long-term immunosuppression. And the one on the right is a young lady who had a history of hypothyroidism and actually had systemic EBV, required a bone marrow transplantation, and died. So they were all clearly thyroid eye, but some of them were, some of them weren't. So always important. I'm always grateful. I'm able to talk to my endocrinology colleagues and other colleagues. And again, you know, besides making the correct diagnosis, it speeds up the diagnosis. And where the window, well, the traditional window for treatment is relatively narrow, it makes a huge difference if you make the diagnosis earlier by 10 months. So what's the incidence and prevalence? So, you know, was classified as a rare disease, but of course it's fallen out of the classification of rare disease because of the advent of the new treatments. A lot of people, they realize it's actually not that rare, and then it's been reclassified. But it's much more common in women than men as a normal autoimmune disease. The peak age is 40 to 60, a very productive time in patients' lives. And so, and bearing in mind again, you know, the traditional classification, about 2/3 had mild disease. But bear in mind, this is mild, we classify it as mild, doesn't mean it's mild to the patient. 1/3 had moderate disease, which is amenable to immunosuppression. And about 2 to 5% have sight-threatening disease. Can be grossly asymmetrical. Some of them may be euthyroid. So there's a huge mix. And it doesn't always parallel the thyroid activity. So roughly about 3/4 will have the eye and thyroid disease onset within the same year, but they can be hugely temporally disparate. And there's a small proportion who actually have the eye signs and of those, roughly half will go on to develop some form of thyroid dysfunction. So again, this constant dialogue with endocrinology is something we greatly value. And also important in the mix that about between 8 to 18% can have other autoimmune conditions that require treatment. And both the ATA and the ETA guidelines is that the achievement and maintenance of euthyroidism is key to the management of the disease. Well, looking at who's at risk, so there are 8 risk factors: family history, age, gender. Males get worse disease, but they're less likely to get the disease. High TRAb titers, radioiodine, thyroid control, smoking, and high cholesterol more recently. And only the bottom 4 are modifiable. So I shall go a little bit into describing how to modify these risks. And you go to come up with this Prodigal score, which again predicts the likelihood of a Graves' patient developing eye disease based on CAS, TRAb titers, duration of hypothyroidism, and smoking. And they concluded a score of 6 or less means that the patient is at low risk. But it doesn't, it's not a direct correlation if the score goes above. But just something to think about these factors when you're looking at your patient. Smoking has been known for over 30 years is bad news for the eyes, and I always say that if the patient doesn't stop smoking, and actually because it's such a disabling disease, it's one of the best stopping smoking conditions to stop the patient from smoking. If they carry on smoking, often it's very, very difficult to stop them smoking, but they do badly on every aspect: risk of visual loss, response, relapse. And our patients who are smokers, the disease has been going on for 10 or 15 years. So of course there's the vaping. So people ask me, is vaping safe? There's been no large-scale studies done on vaping. It's something we should do. Because smoking is so bad, I tell my patients probably not as bad as smoking. It's probably not as good as not doing anything at all. So it's one of my standard phrases. Radioactive iodine is recommended for NICE as first-line treatment. But those of us working in the thyroid eye has been always haunted by the Bartolena paper in the late 90s, showing that patients who have TED can have worsening or exacerbation of their TED after radioiodine, but that prednisolone protects. So our team at Imperial have been looking at radioactive iodine in the new kind of paradigm management. We found that there was actually, if you choose your patients carefully, there's actually a low progression rate, about 2% on over 231 patients. We generally tend not to give radioiodine to patients who had immunosuppression for their eye disease. We give steroid cover if there's any signs of eye disease, and then those who don't have anything can go ahead as normal. So again, I always use the Prodigal score to think about their risk factors and to advise whether to use steroids or not. But it's good to remember that the TRAb titer, the TSH receptor antibody titer, doesn't come down after radioiodine and does stay elevated for many years. So patients with very high TRAbs, you may want to consider other treatments, even long-term medication where it's appropriate. I'm not going to tell you to do your jobs. So the big question always is, does thyroidectomy confer additional benefit? And again, the literature is split. There are some that say it makes no difference, and there are some that do. I'd like to draw your attention to this paper from Germany in 2016. They looked at 50 patients, those who had early thyroidectomy and those who had later thyroidectomies with severe eye disease, and they felt that generally those who had early thyroidectomy did better. So in our practice, we tend to consider earlier thyroidectomy in patients with severe sight-threatening TED with high antibody titers. And these patients are likely to need some form of rehabilitation later on. So it's good to make that decision early. And again, as I'm speaking to a group of endocrinologists, is I make a plea, please communicate to your ophthalmologist about the long-term plan for this patient, whether you're going to just hope that they go into spontaneous remission, whether you're going to give them radioiodine, thyroidectomy, or just leave them on medications forever. Because it means that the patient can move on and we can treat them. Otherwise, they're living with the disfigurement while we don't know what the plan for their thyroid is. So it's really valuable if you can tell the ophthalmologist, I plan that this patient is going to have 18 months of treatment and then they will go into spontaneous remission and you can operate on them then. Really appreciate us telling you, you telling us. So communication. So I'm going to talk about antibodies. So if we look at the TSH receptor, it can be blocked or stimulated, or it can be neutralized. Case 170 is the blocking antibody. And it's co-located on the orbital fibroblast, which is the kind of main driver of the orbital disease. It's co-located on the IGF-1 receptor, and more of that later on. And bear in mind there are three types of antibodies: the stimulating one, which causes the thyroid condition, the blocking one, and the neutralizing one. And you cannot tell which one when you do an order blood test. You can only differentiate between the three using cell-based bioassays, and that's not widely available in the day-to-day clinical practice. So just talking about case 170 has been trialed in a phase 1 trial and is undergoing phase 2 trials in Japan. And what is interesting is that anecdotally it seemed to improve the eyes and reverse the hypothyroidism. So it's something to watch, but unfortunately it hasn't really been taken up. So I'm very looking forward to having more trials on this because it'd be great to kill two birds with one stone. But overall, there's a lot of publications saying, can we just do a blood test and it's like a crystal ball how the patient go? And this paper that looked at different assays and the cause of eye disease shows that it's probably predicted that you have a very low antibody titer. Most likely that patient is not going to run a fulminant TED course. And those with high antibody titer are at significant risk of having a fulminant TED course. But in between, you really can't tell. So, but please check it anyway, because if it's negative, we really have to think about other causes of the orbital condition. And there are many available assays as well. So it's one assay is negative, it's worthwhile asking for a different one. What about the other antibodies? So they're often elevated in grades, but TPO, the row is unclear and slightly controversial in TED. And there may be a protective element of thyroid globulin antibodies. I don't routinely check them, in the eye practice. Of course, you will want to check them from your side for other conditions, but I don't find them particularly helpful. Of course, TPO has a role in the Hashimoto's, but often the other ones with eye disease are also receptor positive as well. So in terms of describing thyroid eye disease, the two buzzwords are you need to describe their activity and the severity of their disease. I'm going to look at what tools we currently have to do that. So everybody's familiar with the CAS score. It's described by Moritz in the 1990s. It's a common language between endocrinology and eye doctors. It describes inflammation, redness, pain, swelling, and impaired function is only taken into account at subsequent visits. It's a binary score, present or absent, and developed in the Netherlands, mainly on a white population. I'd urge you all to download the Ugogo CAS score atlas. You can get it on from the Ugogo website, and you can score for each of these factors using the reference templates. And you can see that predominantly, again, most of the patients are white. So in a multi-ethnic population, it's much less reliable. But it goes through every aspect, and you don't need a slit lamp really, apart from the bottom to the score chemosis. So the idea is that any thyroid eye specialist, regardless of their underlying discipline, can score. The problem is that the loss of function is only measured at follow-up. So if the patient has dreadful vision, dreadful double vision, you can't score them if you're seeing them for the first time. And if you look at the loss of function, you need to look at their acuities and see whether the 2 lines are dropped. You need to measure their proptosis. And you need to do these Dutching tests, which are extremely time-consuming. So in practice, very few people actually score them out of 10. And this paper, which is published by Ugogo colleagues, showed that even among experts, there's a huge variability and that it really needs improvement. But it's the best thing we have at the moment, so we use it, but it is very flawed, and we acknowledge it's very flawed. In terms of the severity classification, again, this is classified that 2/3 don't need treatment in our eyes, 1/3 need treatment, and 1/3 need urgent treatment. But this is predicated on what treatment we have, which is immunosuppression. And that is when assessing the quality of life really helps to close the gap with what's happening with the patient and what we classify them as. Most of my patients with mild disease are miserable. So I would urge that we move to a much more multimodality assessment, where clinical assessment is only part of a very big picture, that you're photographing, doing their ocular motility, asking their quality of life. I use a lot of radiology, and of course, never forgetting the looming presence of the thyroid in the background as well. And so again, of course, the worst fear is with our patients going to go blind from their disease. And the Ugogo publication is not very helpful because a quarter had CAS less than 3, a third had no proptosis at all, roughly about a third had other eye conditions that can cause vision to go down. And they found that if you can check Ishiharas, that would be really helpful. If the vision's down, of course, that's helpful. And if you scan them, if it's very tight, very large muscles at the apex, they're at higher risk. But again, there's no gold standard sign. So we looked at our own database of over 550 patients and looked at what other factors contributed and would ring alarm bells when you see patients in your clinic, whether this patient is at risk of losing their eyesight from their eye disease. We found that patients being older, having terrible double vision, diabetics, and a relatively high TRAB did increase the risk. So when you see patients with all these kind of factors, that please think about, is this patient going to lose vision in their eye, from their eye disease? So one of the problems is that, I'm going to talk about TRABs in a moment, is that it's based on these very flawed paradigms that the initial trials on the new agents for thyroid eye disease were designed. And unfortunately, going forward, because for FDA approval, they have to replicate that, there's a straitjacket in terms of where you can, how these trials are designed, because everything has to replicate the initial trial to show efficacy. So unfortunately, it's a condition of having, not very great input and leading to slightly better looking, but not, quite unreliable outputs as well. So we're at this very frustrating, stage. So understanding of the pathophysiology has driven the advance of the therapeutics in this area. This is a slide taken from our paper showing the activated orbital fibroblast is the center for the receptors, but there are lots of cytokines in play, the recycling of antibodies, but ultimately it leads to antibiogenesis, deposit of hyaluron, and the myofibroblast proliferation. And what happens is that there's tissue remodeling in a very confined space of the eye socket, ultimately leads to the signs that proptosis and double vision, because the eyes, the muscles are not moving together. And so, the analogy of overpacked suitcase and, sprained muscles is what I often use for my patients to explain their condition. But actually, with the advanced photography techniques, we can see actually it's not just the orbit that expands, actually the whole face, all the facial fat pads expands. So we need to think about TED actually being an oculofacial disease instead of just an orbital disease. So what about treatments? And that's when, it's been really exciting. So we need to think about the original paradigms for gauging any successful TED treatment. First of all, it should restore visual function, stop visual loss, stop the double vision. We should reverse the disfigurement. This is something that really, really distresses our patients because of the terrible disfigurement they have to live through. And it needs to have a good safety profile. So where did we come from? So when I was training, if everybody got 60 milligrams of prednisolone and were not very effective, they still looked terrible, they gave them Cushing's on top. Then we moved on to the Ugogo regimen that we gave them IV steroids, and CellCept was added as a second-line agent in 2021 to start together with the IV steroids. And we, in the acute phase, will reserve as surgery, decompression surgery for patients with really sight-threatening disease, which are not responding to the higher dose of sight-threatening protocol of Ugogo. However, we are moving into the era of targeted treatment, which is heralded by the advent of the approval of Tepezza, which I'll talk about it a little bit more. Why do we need new treatments? The answer is, one of the most challenging things that we treat in thyroid eye disease is the terrible double vision. It really is disabling for our patients. They can't drive, they can't work, and steroids are not very good. I said to our patients, I've got a 50% chance that you'll respond. So, and another thing is that IV steroids do nothing for the proptosis. So, what used to happen is that 18 to 24 months after the onset of Graves' disease or more, given NHS waiting lists, if patients have bad disease, they may need to have 3 surgeries. They will need to have an orbital decompression done in a sequence to put their eyes back. And then if they have terrible double vision, they have squint surgery to try to get their eyes better aligned so they don't have double vision all the time. And then we have lid-lowering surgery. So you're talking probably from patient from onset of disease about 5-6 years before they can go back to a semblance of normality in people with severe disease. Of course, looking to the future, in the ideal world, we'll just give them something like K170, not necessarily that agent, that can reverse both hypothyroidism and TED. That would be the kind of dream, but somewhere we're somewhere in between. But the new treatment paradigm is that with the new agents, we can address the inflammation and the disfigurement simultaneously while we're waiting for their thyroid disease to settle. So this targeted treatment can target many components. I'm not going to go into this because I talked about it in May. And reference you to the lecture, but they can be B-cell depletion, IgG recycling, cytokines, transmembrane signaling, or at the receptor level. So I'm going to start with the receptor level because that's where there is an agent that's approved by the FDA. And interestingly, it doesn't target the TSHR receptor, but actually targets its sister receptor, which is the IGF-1R receptor, and they crosstalk. And so teprotumumab was a repurposed sarcoma drug that was put into clinical trial, and it's a partial antagonist of the IGF-1R receptor and stops downstream signaling. So the phase 2 studies started in 2017, and then phase 3 in 2020. In the same year, they got FDA approval, fast-tracked. And of course, there has been a huge, money changing place, and this really, really kick-started a revolution and a race to start finding new therapeutics for this disease, which had been neglected for many, many years. So if we look at the teprotumumab results in the short term, and bearing in mind that this is always against placebo, not against IV steroids, it does have impressive response in the acute phase. And it seems to cleverly treat the worse eye better than the less worse eye as well. So the eyes shrink back proportionally. And at 1 year, this response in the trials were maintained in roughly 2/3 of the patients. So it dropped down in efficacy. So of course, it went on to an extension study because the non-responders went on to the optic extension study, which is the phase 3 trials. So this is kind of follow-up regimen for the trials. And the George Kahale recently published the long-term follow-up from the trials, of course, bearing in mind that these are diminishing numbers. And he reported that 82% did not require extra treatment, like any of the surgery, over 99 weeks following the final dose. And what is interesting is, of course, they found that actually there was a response in chronic patients as well. And that kind of overturns the paradigm of Rundle's curve, that the static phase is actually not static, because it's still, something is still responding. So what is happening in real life since teprotumumab was approved in the USA? So we know, the known knowns are that it caused high blood glucose, especially in pre-diabetics and diabetics. It's very bad and contraindicated in patients with inflammatory bowel disease. It's vastly teratogenic. But this emerging issue of hearing loss has been a specter that has been rising and rising, and it roughly divides into 2 categories. Those with actually true sensory hearing loss and eustachian tube dysfunction. But a recent patient-reported study showed that it increased the rate of hearing problems by 24-fold. In response, Amgen, who has now taken over the drug, has brought out these best practice guidelines to try to help physicians manage the condition. There's a major class action suit looming in the USA for patients with hearing loss against the company. And in practice, is that if you use the drug in practice and you give it to everybody with thyroid eye, this study showed that actually 2/3 of some degree of regression within 1 year. So the maintenance effect is not clear cut. So of course, fast on the heels is another drug along the same category, veligrotug, made by Viridian. And this is a specially designed molecule The idea is it's meant to be a complete antagonist, so it blocks it completely, so you can give a low dose and fewer doses. That's the theory. And they have just published their phase 3 top line results. And given that it's 5 infusions, it compares again favorably to placebo in terms of proptosis, double vision, and CAS overall. And what is to be applauded is that it actually used imaging, and actually because the measurement of proptosis is so highly variable that they actually confirmed it in imaging studies, and it showed that there was a good correlation. So that's something that can be applauded. It was well tolerated, 96% completed all doses, and they were very safety conscious. They did audiometry for every patient before every infusion at screening, and they thought they found a sort of 1 in 20, adjusted hearing impairment. But most of the patients with this did complete the trial because it was subclinical. Other agents which are on the block are looking at IgG recycling, and this is mainly with the neonatal FcN receptor. And so this is these are a lot of them are repurposed myasthenia gravis drugs. So bactrimab and efgartigimod. So the idea is that you inhibit the IgG recycling, so that's less IgG to stimulate the inflammatory cycle, causing TED. Another group of drugs in current clinical trial is looking at the cytokine blockade. So the 2 main groups are IL-6, so tocilizumab is already used off-label for TED quite widely, but there is satralizumab and hormeline, which are coming onto clinical trials or in trials, and IL-11 made by Lassen as well. So these are trials that we don't have results for yet. So in a brief summary, if we look at the criteria we set for effective TED management, so in conventional medical treatment, we know it's good for treating visual loss. It's not great for double vision. Is really useless for reversing proptosis. We know what the long-term safety are as longevity are. It doesn't make our patients much happier giving them conventional treatment. The new treatments have not been widely used in visual loss because the trials specifically excluded patients with with sight-threatening disease. It's probably better for double vision. It's still a very tricky thing to treat because the eyes need to be just very slightly misaligned to give you double vision. It does seem to have an effect on proptosis. We don't know about the long-term safety and longevity. We have some experience with the short-term complications. And it does make the patients happy while they're waiting for their thyroid to settle down. So with these agents, again, there's a move, actually very much all the new trials coming out are mainly on subcutaneous agents as well. So we have been treating with infusion agents. So there'll be a much more, bring it in line with other treatments for other autoimmune conditions. And we're probably looking at some agents which are better at induction. The IGF-1R receptor antagonists seem to be very good at induction, but in terms of maintenance, maybe there are other agents which are better. So it remains to be seen. And surgery will still have a role to play, but possibly a diminishing role. But the main thing is the elephant in the room is money. A course of teprotumumab in the USA is $400,000 US, and steroids are cheap. And so we are at risk of creating a global north and a global south in the treatment of TED. Steroids will still have a role to play because this is unaffordable. So I would say the take-home messages from my talk to an endocrinology audience is, please check the TRAB. It's really helpful, and check it more than once because it's useful to know what they're like after treatment and at baseline. Try to optimize the risk factors, talk to your ophthalmologist. Do encourage you to download the YouGoga Atlas. It's free and you can put it on your phone, and then you can try scoring the cats, not scaring the cats. Please communicate to your eye doctors about the long-term thyroid plan for your patient. Please think about having a multi-faceted TED assessment and close the qual gap. And the goal qual is available online. We have it built into Cerner here. I've arranged for our society to host the goal qual tool on our society's website. So for those of you who want to access it, I'm very happy to share it quickly so you can use it as well. And multidisciplinary management is really key, especially in the new paradigm, because we're dealing with monoclonals, and really we are eyeball doctors. So really appreciate your support in this brave new world going forwards. Okay, so And yeah, for those who are interested in therapy, this is the open label, not open label, open access publication that we have. Sorry, there's some overlap with my May talk. Kareem told me not to, but it's a rhythm. And we are running these trials currently at Imperial. So for those of you who want to refer your patients to trial, please email this email, and then we'll pick it up and take it forwards from there. They're not all recruiting at the moment. They will come and go. These are all the trials we're likely to run. And finally, I would like to thank you all for listening. I'd like to thank my MDT colleagues. Many of them are sitting in this room. And most of all, my patients who have taught me everything I know about this disease. Thank you.
Right, any questions? Okay.
Yeah. We're going to get two different perspectives now, both from a nuclear and a surgical perspective.
Thank you so much for that. I'm really privileged now to introduce Dr. Simon Khan, who's the lead nuclear medicine consultant here at Imperial. She's a research expert in theranostics for prostate cancer and urinary cancers. Thank you, Simon.
That's here, yeah.
Oh, is that right?
That's it, stop this noise, I'll move that away. Okay.
Good morning, everyone. Thank you for the warm welcome, and thank you to the organisers of the Endocrine Symposium for inviting me to speak on the topic of radioiodine treatment in Graves. How is it done and how does it work? My talk will be covering the concept of theranostics and the mechanism of action of radioiodine. I will be briefly covering thyroid scintigraphy and its relevance to radioiodine therapy, the indications and contraindications for treatment, procedure details and post-treatment care. We'll briefly discuss the side effects related to treatment. And I will also present some of our radioiodine audit data from Imperial. So, radioiodine has been around for quite a while now. It's been used for the treatment of hypothyroidism for more than 80 years. Dr. Saul Hertz, who's pictured in this slide, was the first physician to develop the medical use of radioiodine and apply it in a clinical setting, successfully administering a therapeutic activity of radioiodine to a patient with Graves in early 1941 and later for the treatment of thyroid cancer in 1946. The clinical use of radioiodine also represented the first application of the theranostic concept in nuclear medicine, which remains to this day the cornerstone of radioligand therapy. What is theranostics? Theranostics is essentially a form of personalised medicine in which diagnostic and therapeutic radionuclides that share a specific target, be it an antibody, receptor, or small molecule, are paired together for both diagnosis and treatment. The benefits of this unique approach, whereby we utilise the same molecular target for both imaging and therapy, includes precise diagnosis with accurate identification of the disease state, appropriate patient selection, identifying those patients who will benefit from treatment and excluding those who will not. It offers targeted treatment, limiting damage to healthy tissues, and it provides personalised care whereby treatments can be tailor-based on individual molecular targets. With regards to radioiodine theranostics, we've exploited the ability of follicular thyroid cells to take up radioiodine via the sodium iodide symporter in the same fashion as stable iodine is absorbed from dietary sources. So essentially, the sodium iodide symporter is our target. Once iodine 131 has been absorbed by the thyroid, it decays predominantly by high-energy beta emission, which results in DNA damage, cell death, and ablation of hyperactive thyroid tissue. The beta particles have a very short range in tissues of about 0.4 millimeters, which minimizes systemic effects whilst providing targeted treatment. With regards to thyroid imaging, which is the diagnostic part of the theranostic concept, we need to confirm that the thyroid will take up radioiodine prior to treatment, otherwise there is obviously no point in treating a patient. And we can do this by performing thyroid scintigraphy, also known as a thyroid uptake scan. The imaging radionuclides of choice are technetium-99 and technetate or iodine-123, both of which decay by gamma emission, which we can then image in nuclear medicine with our gamma cameras. Although iodine-123 is a more physiological choice of imaging agent in that it is trapped and organified by thyroid follicular cells, Techne-99m is an excellent surrogate and is by far more widely used. Technetium-99m technically is trapped but not organified by the follicular cells, but it has the benefits of being more easily produced. It has a lower radiation burden in that Techne has a half-life of 6 hours versus a half-life of 13 hours for iodine-123. It has a much quicker imaging protocol. We can do the whole test in about an hour, whereas it's a 2-day protocol for iodine-123. And not forgetting, and probably most importantly, it's cheaper. So I thought it would be useful to go through a few examples of cases that we would potentially treat with radioiodine. But as with most examinations in nuclear medicine, it's always useful to know what is normal. So here is a normal thyroid technetium-99m uptake scan, which demonstrates diffuse homogeneous uptake of tracer throughout both lobes of the thyroid, as arrowed in purple. It's very normal to see salivary gland activity as marked by the green arrows, and it's also normal to see background soft tissue activity as marked by the red arrow. We do normally place a cobalt chin and suprasternal notch marker, which you will see on the next slide, and that's for anatomical localization and helps delineate the presence of ectopic tissue, pyramidal lobes, and retrosternal extension. We can also perform an uptake function calculation, and we do this by drawing a region of interest around the thyroid, a region of interest around background soft tissue, and then a normal uptake function is between 0.4 and 3.5%. So here we have a classic example of Graves on the thyroid uptake scan. The image on the left includes the chin and suprasternal notch markers I've just mentioned. The image in the middle is of a patient that has diffuse, homogeneous, intense, increased uptake of tracer throughout both lobes of the thyroid, with abnormal suppression of the normal salivary gland and background activity. On the right, we have an image of the thyroid uptake calculation. I know it's impossible to see those values, but I can assure you that the uptake function is markedly elevated at about 21%. This slide portrays how we can nicely differentiate some of the causes of hypothyroidism on a thyroid scan. So the top left image is another classic example of Graves. The image on the top right demonstrates a toxic multinodular goiter. On the bottom left, we have intense uptake within a nodule arising from the left lobe of the thyroid with suppression of activity in the contralateral lobe and salivary glands in keeping with a solitary autonomous nodule. And on the bottom left is a classic example of subacute thyroiditis with no discernible uptake within the thyroid above that of background activity. So my question to the audience would be, which of these patients would not be suitable for radioiodine treatment?
Okay, I think that's quite clear.
Yeah.
And talk with Dean in the chat as well.
That's quite an easy question. Everyone seems to get that right. Yeah, the answer is subacute thyroiditis. Obviously, if we gave this patient radioiodine, the thyroid's not going to retain that radioiodine and it's not going to work. In terms of indications for use, there are a number of indications for radioiodine in the treatment of hypothyroidism, but those relevant to Graves and representative of the patients we most frequently encounter in clinic include persistent severe hypothyroidism despite antithyroid medication, recurrent hypothyroidism post-antithyroid medication withdrawal, intolerance to antithyroid medications. There may be patient preference for definitive treatment. Often we see patients that want to plan a pregnancy in the foreseeable future, troubling symptoms such as severe arrhythmias and candidates that are of high surgical risk. Absolute contraindications include pregnancy. All patients of childbearing age are required to fill in a pregnancy questionnaire form. And if there is not a valid trust-approved reason for not being pregnant, the patient will undergo a serum beta-HCG 48 to 72 hours prior to treatment. Breastfeeding should have been discontinued for at least 6 weeks prior to treatment. Relative contraindications include very large goiters. This isn't really relevant to the Graves cohort. We do occasionally see patients with toxic multinodular goiters or non-toxic goiters, in which cases we always make sure that they have up-to-date, non-enhanced cross-sectional imaging so we can accurately measure thyroid volume and assess for severe tracheal narrowing. Any patients with severe tracheal narrowing of about less than a centimetre are treated under steroid cover. We can also consider doing inpatient treatments to address any possible post-treatment complications. Another relative contraindication, which Vicky's already been through, is active moderate to severe Graves' eye disease, especially those patients with high TSH receptor antibodies, and if smokers. We're very fortunate here at Imperial to have such active support from Vicky and her team, and if we have any concerns of eye disease, if there's any whiff of eye disease, they'll be reviewed by oculoplastics to assess A, is radioiodine indicated, and if so, does it need to be done under steroid cover, which we prescribe as per UGOGO guidance. So all patients are referred for radioiodine are reviewed in a dedicated clinic, which is run by myself and one of the nuclear medicine physics team. We found that these consults are essential and an opportunity to assess clinical status, discuss the goals and expectations of treatment, addressing patient concerns. We go through the logistics of treatment, any potential side effects, and it's also an opportunity to obtain informed consent. Here's the clinic pro forma that we use at the pre-therapy consults. Dr. Cox, you may be worried to see that you're the default setting for referrer on this pro forma. We start by taking a brief history to assess for any particularly troublesome symptoms and that we may anticipate will be a problem when stopping their anti-thyroid medication. We assess their thyroid status with up-to-date thyroid function tests and ensure that their thyroid scan is amenable for treatment. We'll run through any potential contraindications, which I've already briefly discussed. We'll explore any potential drug interactions, and we consent all patients for hypothyroidism and treatment failure. If the patient is keen to proceed with treatment, we aim to get a date in the diary at this consult so we can let patients know the exact dates they need to come off their carbimazole or PTU and when to start their low iodine diet, which we ask them to adhere to 2 weeks prior to treatment and 3 weeks after. In terms of drug interactions, there are a number of drugs and iodine-containing substances that can interfere with radioiodine thyroid uptake and therefore reduce efficacy of treatment, and they're listed on this table. I just wanted to highlight a few that are of particular interest that require quite long withdrawal periods. So that includes lipophilic IV contrast agents such as lipiodol, that doesn't include CT agents, which have a shorter withdrawal time. And then also amiodarone. Both of these agents require a 3 to 6 month withdrawal period or longer. Whilst on the subject of drug interactions, it's probably worth mentioning lithium use, which has the potential of increasing retention of iodine 131 in the gland without reducing iodine uptake. Presently, its clinical significance on radioiodine therapy effectiveness is not completely clear, but some literature has shown that adjuvant short-term use of lithium, so between 7 to 10 days, can increase radioiodine therapy efficacy without an increase in side effects. At Imperial, we may consider its use for patients with particularly high uptake values or very low uptake values on their thyroid scans. We tend to prescribe about 800 milligrams at night for 10 days and ask patients to take it for as long as they can. And this is in line with EANM guidance, which suggests that the use of lithium can be considered on a case-by-case basis if radioiodine therapy is not felt to be feasible without it. The concept of the low iodine diet is that we want the thyroid to take up radioiodine in preference to iodine from the diet. It's probably not as important in benign treatments compared to malignant therapies, and each centre will have slightly differing advice. Here at Imperial, we provide this traffic light system, asking patients to avoid foods in the red box completely, which includes fish, seafood and sea salt, amongst others, and then foods in the yellow box should be limited where possible. Our physics colleagues will then perform a radiation protection risk assessment, paying particular attention to the contacts that patients see regularly and or for prolonged periods of time. So we want to know who's living at home, do they have children, if so, how old are the children at home, do they have any regular contacts with kids or pregnant ladies outside the home, for example, at work? With regards to occupation, what do they do for a living? What is their work setup like? Do they sit in close contact with others for extended periods of time, etc., etc.? Radiation protection precautions are then calculated by the physics team according to the ionizing radiation regulations 2017, working with a dose constraint to patient contacts of no more than 1 millisievert per year. This table's a little complicated, but I just wanted to highlight for adults at home, we advise patients not to have any prolonged close contact, prolonged close contact being less than a meter's distance for more than 30 minutes a day, between 7 to 10 days. These values obviously increase when there are kids at home. If the kids are of school age, we would say to avoid that contact for 14 to 16 days. If the patient is, for example, a primary carer for an infant, then those precautions actually extend quite significantly. So you're looking at 24 to 27 days. So in this cohort, radioiodine just may not be feasible, and then often patients may consider surgery. I'm just going to go back.
Yeah.
Yes, I can. Okay, yeah, going back to this questionnaire, I just wanted to highlight that we also ask patients about any travel plans. So we ask patients to avoid long haul distance flights for about a month after treatment. We have had patients set off radiation detectors at ports and airports, which is always very interesting. So we'll give patients a letter to say that they've had a medical exposure so they can show it to security if that were to happen. We also tell patients not to fall pregnant or to father a child within 6 months of treatment. So what happens on the day of administration? So the administrations are performed by the physics team under a nuclear medicine consultant's RSAC license. The patient's ID will be checked, pregnancy status will be confirmed if relevant. The radioiodine is administered orally as a capsule. We always tell patients it's the size of a paracetamol, so that image on the top confirms that it actually is. Some centres recommend that patients fast overnight and for 1 to 2 hours after treatment to encourage gastric absorption, but we tend to ask patients to just have a light breakfast and to preferably avoid going to an all-you-can-eat buffet post-treatment, as radioactive vomit is every medical physicist's nightmare. Following radioiodine administration, we encourage patients to drink plenty of fluids for about 24 to 48 hours, which helps reduce the radiation absorbed dose to the bladder. We'll run through radiation protection requirements again. We'll ensure steroids or lithium prescriptions have been picked up if needed, and then we'll remind the patients of their follow-up, which is done by our amazing endocrine CNS, Debbie, by the telephone clinic. She'll organise bloods roughly 3 weeks for 12 weeks after treatment, and she'll aim to start thyroxine when the T4 levels fall below 14. So what happens to the patient once they swallow the capsule? Oops. Well, I think some patients are a bit disappointed that this doesn't happen. In actual fact, not much really. It's a bit of an anticlimax. So I'll have the radioiodine capsule and go home about 20 minutes later. We know that the therapy is safe and generally well tolerated, but acute or late side effects can occur, as summarised in this table. Early side effects can include thyroid swelling. Patients can experience some pain and tenderness overlying the thyroid due to local inflammation. And we tend to just recommend simple analgesia, and we assure patients that it will subside within about 24 to 72 hours after treatment. Thankfully, radiation thyroiditis resulting in a thyroid storm is rare. It's reported as approximately less than 1% in the literature. Post-therapy thyrotoxicosis with a transient rise in thyroid levels is slightly more common in about 10% of patients. We always warn patients that they may experience their thyrotoxic symptoms when they come off their thyroid medications and waiting for the radiation to start working. We'll ask patients to let the endocrine team know if they've got any troubling symptoms, and they may be prescribed beta blockers to tide them over. Radiation-induced thyroidinitis I've actually never seen in a benign setting. It's probably more frequently encountered when treating with high radioiodine activities for thyroid malignancies, and Graves' orbitopathy, Vicky has already covered. When it comes to dosing, there are generally two schools of thought. Do we go for a functional approach versus an ablative approach, whereby a functional approach concept aims to achieve euthyroidism as soon as possible, and the ablative dose approach aims to achieve hypothyroidism as soon as possible? Based on evidence, the definitive success rate in controlling hypothyroidism is much higher with an ablative approach, greater than 90%, versus less than 70% with the functional approach. In addition, the ablative approach can result in thyroid gland volume reduction, which may have both mechanical and aesthetic benefits. So E&M guidance currently favours the use of an ablative approach for all Graves patients, given the high rates of recurrence with the functional approach. Here at Imperial, we follow a fixed dose ablative approach, whereby all our patients will receive 600 megabecs of iodine 131, and a small percentage may receive 800 megabecs if, for example, they have a particularly large gland, or if we are doing a retreatment. So just briefly, we performed an audit to assess our current success rates in treating hypothyroidism with radioiodine at 1 year post-treatment. We reviewed 257 patients, 194 patients had Graves' disease, the remaining had a toxic nodule or toxic multinodular goiters over a 6-year period between 2016 and 2022, and we compared the results with a previous audit. Approximately 96 patients became hypothyroid or euthyroid within a year of treatment. Previously, that was 95%. And you can see it's much better than the 85 to 94% quoted in the literature. We had approximately a 3% failure rate. That was previously approximately 5%. 75% of patients became hypothyroid or euthyroid within 9 weeks. And the most common time to become hypothyroid or euthyroid was actually between 1 to 3 weeks post-therapy. Previously, that had been 7 to 9 weeks. So, in summary, radioiodine is the first-line treatment for definitive treatment of hypothyroidism. It's a safe and effective treatment for Graves with few complications. The majority of patients achieve remission with a single dose. Success depends on patient selection, dosing, and follow-up. And as with most things in medicine, a multidisciplinary collaborative approach between the endocrinologists, ophthalmologists, surgeons, and nuclear medicine physicians is key. And with that, I thank you for your attention.
Thank you. If everyone's happy, we'll do questions at the end. So I think Vicky gave a really nice description of the presence of the thyroid gland in her talk as being a looming one. That I was actually thinking while sitting at this table, we have a looming presence of David Scott Coombe, or maybe a luminary presence. So David's an endocrine surgeon in Cardiff. He's been an endocrine surgeon since 1996. He's the past president of both the British Association and European Society of Endocrine Surgeons. And he's going to talk to us about removing the looming presence of the thyroid gland.
You want to ask a question?
Yeah, why not? Thank you very much. Thank you for your kind introduction, Lady Chairman, if I'm allowed to say that word anymore. Are you doing the question?
I'll do it, yeah, I'm going to share.
I just thought we'd start off with a couple of questions to keep you on your toes.
525610, and then vote for which intervention for Graves' disease results in the lowest rate of recurrent hyperthyroidism. We've got 40 votes already. There's 100 and something people in the room. Okay, so the next question.
Yeah, so the next question has got a Christmas theme to it. And it's who is the odd one out? Is it Professor Theodore Cocker, Professor Theodore Bilroth, Professor Fausto Palazzo, or Father Christmas? And the answers to both of those questions will become obvious as I speak. Okay.
Should we look the answer? See how many voted for, or do we keep running?
Well, yeah, let's
Just keep as a vote.
okay, let's it's illuminated. Okay. Right, well, thank you very much for the invitation. Yesterday was Thursday. Thursday for me is like double maths. Because I did a clinic in the morning in Swansea, and then I did a clinic in the afternoon in Cardiff. And yesterday I saw 5 patients referred to me by 4 different endocrinologists, all wanting me to explain to patients what the advantages and disadvantages, not only of thyroidectomy, but also radioiodine, so that the patients can then make a decision. So we've done that. So you already know that patients are treated with antithyroid drugs since they became available in the 40s. And then for those medical student teaching is you have that for 18 months, you then stop it. And the book saying 50% relapse and 50% stay in remission. The target we would say 80% relapse. And for those where medical treatment has failed, you then have definitive treatment, and as I say to my patients, that's destructive treatment, either by radioiodine, about which you've just been hearing, or surgery, which is my brief now. And the problem with surgery of Graves' disease is that we have been handicapped by the philosophy of endocrine surgery. And the philosophy of endocrine surgery is to return patients to a normal thyroid status. So if someone has hyperparathyroidism, we take the overfunctioning, hyperfunctioning parathyroid tissue away, but we leave normal parathyroid tissue behind so that they are calcemic. Same with an insulinoma, the same with a Cushing's adrenal tumor or a Conn's. But we are strapped by this idealistic philosophy when it comes to Graves' disease. So the ideal operation for Graves' disease is that you cure the hyperthyroidism, let's call it that, all right, without any mortality, without any morbidity, and you return the patient to a normal thyroid status, i.e. they don't need to take thyroxine. And the history of thyroid surgery for Graves' disease is pretty much the same as the history of preventing complications. And the complications are death, injuring structures close to the thyroid, i.e. the nerve, the voice, and the parathyroids, and then endocrine failure, either by leading to hypothyroidism or failing to adequately treat the hyperthyroidism, resulting in persistent or recurrent hyperthyroidism. So let's just deal with mortality, because it's not an issue too much now. In the old days, mortality was a huge issue due to hypovolemic catastrophic hemorrhage. When deaths do occasionally and tragically occur now following Graves' thyroidectomy, it is due to bleeding, but a small bleed, a subtle hematoma, which leads to local edema, leading to vocal cord edema, leading to asphyxiation, leading to death. And traditionally, the other great cause of death was sepsis. So if we whiz back to 1848, William Halsted wrote, and I'll read this to you, "Can the thyroid in the state of enlargement be removed? Emphatically experience answers no. Should the surgeon be so foolhardy to undertake it, every stroke of the knife would be followed by a torrent of blood. And lucky it would be for him," by the way, they're female surgeons, obviously. "If his victim lived long enough to him to finish his holy butchery." And in 1850, France banned thyroid surgery. So enter Theodore Billroth, 1E, from Vienna, who really addressed all manner of surgery, general surgery, but particularly to thyroid surgery. And you can see that the mortality went down to 10% under his hand, but mainly due to the interventions of beginnings of anesthesia, asepsis, antisepsis, and he trained Theodore Cocker from Bern, who again, loads of general surgery, but took a huge interest in thyroidectomy for Graves' disease, and he managed by the end of the century to bring the mortality down to 4.5%. Total thyroidectomy was not advisable. Of course, thyroid extract wasn't available until about 1920, but it was mainly not advisable because of the bleeding. And again, his biggest interventions really were with antisepsis and anesthesia and developing instruments that really allowed minimizing blood loss. And for that, he got the Nobel Prize for Physiology or Medicine in 1909, the year that Moynihan introduced rubber gloves into British surgery. And then Professor Palazzo's hero, Thomas Dunhill, born in Melbourne, ended up in St Bartholomew's, and really missing out from the history books of his contribution until more recently, where he further reduced the mortality. It's harder to get more dramatic reductions when you're on to 50% to 10% to 5%, but he reduced it further to 2%, again, using local anesthesia, using stapes procedures, and unmodestly giving his name to the Dunhill procedure. Most people were doing the Enderlin-Holtz, which is the cartoon to the left, where bits of thyroid, remnants of thyroid were left on both sides, where Dunhill would do a total lobectomy on one side and a subtotal on the other side. When I was a registrar at Hammersmith, every now and then the library used to flog books that they were finished with. So I picked this one up, and within it, surgeon in Bradford Royal Infirmary says, I received a letter from an elderly patient upon whom I performed a successful thyroidectomy some years ago. She mentioned incidentally that 9 months before, her cousin had died after a thyroidectomy, and also that 2 of her neighbours had died on the same day following this operation. So even in about 1950, mortality was still a big issue. In terms of not injuring adjacent structures, the nerve was appreciated for a long time, and really that's something that we are challenged with, but not so much. The big deal for me in particular is not injuring the parathyroid. Okay, so they were of course found by Ivar Sandstrom, an medical student, and then once they were recognized, they were appreciated for what they did, and then people worked out where the blood supply was, and then you started to have strategies to minimize injuring them. And then to avoid hypothyroidism, particularly before thyroid extract was available, but hypothyroidism was reckoned to be the bad outcome. It was very much in the first half of the last century, hypothyroidism was very much a criticized outcome. And so Dunhill made this profound statement that we have to remove enough thyroid to cure the disease, but leave enough behind for physiological purposes. So where are we by about 1960? Well, Larry Wade, who's 2 generations behind me in Cardiff, he knocked off a paper of 120 thyroid operations for Graves' disease, and you can see that his outcomes, he was actually a very celebrated thyroid surgeon, his outcomes were on a par with almost modern surgery now. His hypothyroidism rate was 4.5%. His hyperthyroidism rate was 0%, but he was quick to point out with only a 3.5-year follow-up, it wasn't the best paper. And then there was the papers of the science of the bleeding obvious, which happened throughout the 70s and the 80s. And these graphs are identical, and they are surgeons trying to be scientific. And they've guessed what they think the remnant is in the left in situ after a subtotal thyroidectomy. And the heavier they think the thyroid is left in situ, the lower the rate of hypothyroidism. I.e., the more you leave behind, the less likely you are to be hypothyroid. But of course, the contrast to that is that the more you leave behind, the more likely you are to risk recurrent hyperthyroidism. And the bigger risk was the patients with a smaller thyroid, because weight for weight, they pack a bigger punch. There's nothing more scientific I can say than that, but that's surgery for you. Okay, so what about recurrent hyperthyroidism? Here's a thyroid surgeon in Australia. Okay, so I would put it to you that recurrent hyperthyroidism is a disaster, okay? Because reoperation is treacherous. We've done a bilateral exploration, we've exposed the nerve, we've exposed the parathyroid. The morbidity of redo surgery is too high. And so the only option, as far as I'm concerned, for my patients, would be radioactive iodine. The one thing that either the patient chose not to have, which in my experience is the commonest reason in this stupid operation, or because it was contraindicated. So it's a really bad situation to be. So much so that I think nowadays the ultimate goal is to avoid hyperthyroidism following surgery. And this is another book I picked up. This was owned by Selwyn Taylor, and all those years ago, that most recurrence of hyperthyroidism are due to insufficient removal of thyroid tissue at the first operation. Struggling to advance. Okay. So there's been lots of literature looking at recurrent hyperthyroidism, in comparing subtotal thyroidectomy versus total thyroidectomy. Most of them retrospective case series, which really got level 5 evidence. All right, one meta-analysis and a couple of randomized trials. There's only one prospective study which compared total thyroidectomy with subtotal thyroidectomy with Dunhill's procedure. Basically, there's no difference between the three groups when you look at the TED, as we're now calling it, post-op TSH receptor titers and complications. Marcin Barzinski, who's already on one of the different slides, all right, he did the randomized controlled trial of total thyroidectomy versus subtotal thyroidectomy. And the important thing is that modern surgeons now can get as good results in terms of low complication rates with regard to the recurrent laryngeal nerve and the parathyroids in a total versus subtotal. It's the old-fashioned idea was that the subtotal thyroidectomy, you'll protect the parathyroid. But then, and there's no difference between the two groups in nerve injury and parathyroid injury, but look at the rates of hyperthyroidism. It is obviously 0 with the total thyroidectomy, and it's 9.5% with the subtotal, and that's the disaster. And then there's meta-analyses, which is saying basically exactly the same thing, 8% recurrence with subtotal versus total, and no difference with contralateral injuries. So we have to wait for America for everything. In Britain, there was the swing to total thyroidectomy happened in the early 1990s, but it wasn't really until now, this paper here, that America finally said that so long as you've got a decent surgeon, total thyroidectomy is the preferred surgical therapy for Graves' disease. So where are we now? My disaster, a lady, a GP in the east of Wales, She had seen, by the time we got to operate on her, 10 consultant endocrinologists. She has subclinical hypothyroidism. They thought it was Graves', but a receptor which you keep changing the name to. When I grew up, it was LATS, then it's TRAB, now it's TSH stimulating. Anyway, eventually she succumbed to needing to have radioactive iodine. But as ever, there was a social reason not to have it this time. Her daughter has epilepsy and often slept in her bed, and they just felt that that was going to have to be for 2 weeks. It's very interesting. In 1996, when I started, as Amy kindly told you, radioiodine patients for Graves had to stay away from their children for a week. Now it's up to 4 weeks. The radiation police, like everything else, was getting in on. So I saw her, I operated on her, and as I've just shown you, I gave her temporary hypoparathyroidism, but it fully recovered. Her voice was absolutely fine, and she was discharged. But the histology said multinodular goiter. Now, interestingly, she'd also had a diagnosis of an ascending thoracic aortic aneurysm. So that was having infrequent surveillance. And last year, 4 years after her total thyroidectomy, which she's then cured, she was getting increasing dyspnea. And you can see her thyroid function was fine. And on this scout X-ray, you might appreciate the sort of opacity in the region of the mediastinum. And she had this mass here and here, and although actually there's not much effacement of the trachea, the thoracic physicians and surgeons are very much of the opinion that this was contributing to her difficulty breathing. So there were lots and lots of multidisciplinary team meetings, and in the end, Michael and myself and Tom, one of the thoracic surgeon, we took out not insignificant chunks of multinodular goiter. So this was totally sequestered. It was 1 billion miles away from my thyroidectomy. Of course, she didn't have Graves' disease. She had Plummer's disease. Okay, so to summarize, there's been the history of thyroidectomy for Graves' disease is the history of the development of lots of things like proper surgery from Billroth to Cockle to Dunhill, with the introduction of antithyroid drugs, the availability, as you heard, in the early 1940s of radioactive iodine. But really the swing from subtotal thyroidectomy to total thyroidectomy for those people who opt for thyroid surgery. So I would conclude that there is no ideal operation for Graves', and that we have sacrificed hypothyroidism on the altar to avoid recurrent hyperthyroidism. So finally, everyone thought Father Christmas, you're all completely wrong. It's Professor Palazzo, because he doesn't have a Christmas beard. Thank you for your time.
Going to move on to our papers now, and first up is Dr. Eamon, who is one of our registrars here, and he will discuss the complexity of thyroid.
We'll take questions after this case, because this case marks the end of the thyroid eye disease section.
The microphone?
Yes. Hello, good morning, everyone. Thank you for this great opportunity to present this complex thyroid eye disease case. My name is Eamon, I'm one of the registrars here at Charing Cross. Brief introduction. We all know that thyroid eye disease is the major extrathyroidal manifestation of Graves' disease. and treatment decisions are based on clinical activity, severity, and the impact on quality of life. Let's start with our case. We've got a 59-year-old female patient with no previous medical history, does not smoke, initially presented to her optician with watering eyes with no double vision. She was diagnosed to have kind of seasonal allergy. 1 month later, she developed right eye swelling, and her journey started from here. She has seen different specialties. She saw a maxillofacial surgeon, diagnosed her with blepharitis, started on some antibiotics and steroid ointments. Then she developed headache because of this right eye swelling. She's seen a neurologist, done an MRI normal. Then she saw a rheumatologist to investigate kind of systemic inflammation. And then finally, she saw an ophthalmologist who we assured her that she does not have any signs of glaucoma and advised her to be seen by an oculoplastic surgeon. She did have some clinical improvement, and she cancelled her appointment with the oculoplastic surgeon. Overall, this period, she did not have any overt symptoms of hypothyroidism, and her thyroid function test was not checked at all. So, a few months later, she started to develop severe pain on the left eye with persistent double vision, impacting her daily life. She finally managed to see an oculoplastic surgeon, and this was her eyes. She had an active moderate to severe thyroid eye disease, and it took her almost more than 9 months to make the correct diagnosis. Why we said active? Because her clinical activity score was 4, with a spontaneous retrobulbar pain, pain on movement, swelling on the pleura and swelling of the eyelids, with severity because she's got lid retraction more than 2 mm, moderate soft tissue involvement, exophthalmos, and consistent diplopia. And her Gauquel score was very high, and she was really very miserable during this time. She had significant restriction of the eye movement with a complex ophthalmoplegia, mainly on the left side. This is the Gauquel score that we've been using. For anyone who uses Cerner, it's an ad hoc. You can use it, and there's different versions with more than 20 languages that can be used for this score. Thyroid function test, as we said, she did not have any thyroid function test checked because she saw us in the TED clinic. Her thyroid function test surprisingly was normal, and her TSH receptor antibodies were 4.7, so high. Few weeks after that, her TSH was low at 0.09, and here we said, let's start on some just tiny dose of carbimazole. And we can see throughout her journey, she remains euthyroid. We know that it has been reported that prevalence of Graves' orbitopathy, they can have a normal thyroid function test and be up to 15%. So, according to the Google guidelines, we went for the first line treatment for active moderate to severe thyroid eye disease with 12 weeks course of IV methylprednisolone and oral mycophenolate, and she remained under the care of the TED MDT clinic. What happened after 3 months? After she finished her IV methylprednisolone, she developed side-threatening thyroid eye disease. So we gave her more methylprednisolone. However, she did not respond to that, and she went to have an urgent orbital decompression surgery. The surgery created some relief in her vision, but she continued to deteriorate. Then we went to the second line treatment, which was 10 cycles of orbital radiotherapy with some high dose of oral prednisolone that we were weaning it. She had some orbital steroid injections for the eye symptoms as well, and she ended up having thyroidectomy. What happened after 6 weeks from the thyroidectomy? Did she improve? Did she not improve? So her TED persisted, and the main thing that her diplopia as well persisted, and her quality of life was still miserable. Some improvement compared to the first image, but the main thing was the constant ongoing diplopia. So what we have decided is to give her a third-line biological therapy with tocilizumab. Fortunately, after the tocilizumab, her pain and appearance has improved, and the most important thing that the diplopia has resolved. This is a summary what we have been doing. We started first with, because it was a moderate to severe active Graves' orbitopathy, we gave the high dose of the methylprednisolone. Because she responded, we continued with the methylprednisolone alongside with the mycophenolate. And then when she developed the side-threatening orbitopathy, the optic neuropathy, she had more higher doses of the methylprednisolone for 1 week, but she did not respond to this treatment, and she went to have an urgent orbital decompression surgery. Then, because she did not really respond to this treatment, we went for the second line, which was, the first thing was the orbital radiopathy with the steroids. And last thing, we gave the tocilizumab, which fortunately made her thyroid eye disease the quietest so far. Few things to remember whenever we see a patient in the thyroid clinic. These are the tools that we should be doing as a registrars and as a consultants. Always make the correct diagnosis, check the thyroid function, check the antibodies, screen them, alert them that they might develop thyroid eye disease. After the diagnosis, encourage smoking cessation and avoid hypothyroidism after the treatment, and always refer to a specialist clinic. The learning points is the importance of considering thyroid eye disease as an early differential diagnosis in patients that present with mild but classic signs. Always check the thyroid function and the antibodies. If it is still unknown what the exact natural history of thyroid eye disease and whether early intervention, especially in this case, can actually prevent the progression to side-threatening disease. Importance of the MDT expertise in the management of patients with the thyroid eye disease, and always have a high state of vigilance regarding the diagnosis. Thank you so much.
I think now would be a good opportunity to open the floor to questions to our three people, to Nikki, Sarah and David. I'll be ready to run around with the microphone.
Yeah. I will too, yeah.
Can I just ask the post-radioiodine, you said you give thyroxine when the T4 goes below 14. Is that just a random thing, or is it you look at the TSH? It's the first time I've heard that approach, which may be great. It's just been someone, maybe Karim, I don't know who came up with that.
Okay, first, it used to be, but now our patients, because they all have the uptake scan before they go in, and they're all quite well controlled compared to when they previously hadn't done. It's not the case now, although it's still, I think,
So the thing about 14 is that because we used to do it without pre-treatment, with prime treatment radioiodine, pre-treatment will come zooming down. And if you capture that 14, then the next one will always be hypothyroid, and we're very keen for iodine to avoid that. We always start thyroxine early, and that was our logic. And it was very non-practice here, and he was very keen to use radioiodine first. And we did a lot of that early on. But once they had antibiotics first, then that didn't quite apply. But the main reason to avoid hypothyroidism.
That's great talk. In terms of the little guide, it says about the difference, like high dose and low dose. Do you have any view about which one it's not really.
No, the answer is I don't give the 750, which will give 500 for 6 weeks and then 250. And we assess the patients every month in our MDT. So if they have a lot of dips after the IV prednisone dose, like by day 4 or 5, you're really having lots of signs, I tend to increase the last 6 doses up to 500. And so that's, I suppose, compensates, so there's a slight modification.
More kind of referring to radioactive iodine, pre-radioactive iodine, with the patient with high dose of prednisone.
Oh, okay, I think you're.
Yeah, so the question is for the people on Zoom is what doses of prednisolone to use? And of course, it's a balance between risk and benefit as always, and most of our patients will get 0.2 milligrams per kilogram, which is, the protocol written actually is fixed dose, so it's 20 milligrams and then tapering. The evidence between all these things does not exist, okay? And so we're balancing the diabetes and organs that you see. There was a question on here about whether we should have done an MRI orbits earlier for the case, I think. Is that something that you would?
Yeah, so MRI is the only modality used because it's a competition of these. What we've developed between Imperial and London Northwest is that we use fusion weighted imaging. And we've standardized our scanners, so we actually have a quantitative measurement of radiological inflammation. The radiological tests I use as a guide always joke to my patients, we treat you, not your scan, but those with very high orbital inflammatory signal, we tend to watch slightly more closely, and also it's useful before we undertake rehabilitation surgery, we have a baseline scan to rescan them to make sure that the signals are still not as high. They don't never return to normal. But the answer is MRI is useful, but if you do this classic stir, which an MRI, it varies from scanner to scanner, so you can't compare between scans. It's either more or less active, which is a qualitative decision by the radiologist.
Can I ask a question? What patients with eye disease develop asymmetry? It's an antibody-driven thing. Should it be a symmetrical condition?
I'll just repeat that for the people on Zoom. The question is, why is eye disease asymmetrical? Well, they can hear from there because it's pointing at you, really. But yeah.
So I don't really know, but it's quite remarkable. Is that with the new IGF-1R receptor, antagonist, that they can nose to shrink one side more than the other, though you give the same dose systemically, and that's quite clever. But we still don't know the mechanism. It may be that essentially the destruction of the organ. There's no clear answer.
And I'll repeat the
Hi.
question here.
Okay. A question about use of PSI, parastimulating immunoglobulin. It's a research tool, but it's been shown to predict or to correlate well with disease activity and potential treatment and the results of treatment. Are you aware of?
Yeah, so as
I'll just repeat that. It's like TSI. Sure.
So first of all, it's always a little bit difficult to know what type of antibodies we are measuring. So it can be a mixture of all three with immunoassays. But generally, in that study by Store, you can see that if the antibody level is very low, generally it predicts the eye disease will run a more benign course. If it's very high, it means that the patient may get high risk of disease. But the in between values is what's a grey zone, and you cannot use the to track eye disease. It would be lovely, we just did a blood test and know how they're going to behave. But it's very high, I would say, just watch out. It's very low, hopefully, in between you really can't. Clinical assessment.
Do you think it doesn't add much in addition to receptor, TSH receptor?
Yeah, I mean, I think if you do the TSH receptor antibody in real life, I think unless you have access to cell-based assays, it's going to be difficult to measure. So TSHR is good to make the diagnosis and confirm your diagnosis.
Yeah, there's a question here. Got this microphone here. Take this.
That's a question to the surgeon. In somebody who adopted you then develop three, before you create at which your thyroid anesthetic would be evident to become clear.
Okay, there's a question about anaesthetists, and we will take a to theatre.
Okay, so the first thing to say is this always upsets anaesthetists when I declare who can have an anaesthetic or not. A bit like a large goiter who can be intubated. But basically, I know more than these, and I have no difficulty. So I think the most important thing is how is the patient penetrated. If they've got a peripheral tremor, that's telling you not to do an operation at that stage. We've never seen a thyroid storm, and I don't think we ever should. But if the normal T4, for example, is say 10 to 21, something like that, I wouldn't worry if the T4 was up to 30. And I'm not worried about a suppressed TSH, but it's more how are they doing. The tremor is slightly equal to this, let me die.
Can I come back on that? Obviously TSH is a big lot of concern, but I remember Brian Harrison, who was sort of leading medico-legal person on the day up there in high surgery. And his view was that unless you have endocrinologists who tell you categorically there is no alternative, it's very difficult to defend the complication in a post-thyroidectomy, even if they were thyrotoxic at the time of surgery. And very occasionally we have the patients that they're neutropenic, they're asthmatic, and we have no option to operate on them with potassium iodide and get them down. And often they might not be quite completely euthyroid biochemically. But I feel nervous about it because of what Barney Harrison told me. I don't know what you think about that.
Not too nervous. I think in the patient where you're struggling to render them euthyroid because of needing poor compliance, and you give them Regal's iodine for 7 to 10 days, you then have to operate. You then operate then, they become ragingly thyrotoxic. So I think you can defend operating on someone with less than normal thyroid function tests in that setting.
In that setting, I think the question was about can you operate on a patient who's thyrotoxic?
We check the number of regularly. I mean, the patients who outside of patients with very severe and active disease, for whom you may need to have immediately preoperative thyroid function tests, we're mainly looking at some marginally historic / recent levels, and often giving potassium iodide additionally, but not then rechecking on morning of surgery because you know as long as they're taking everything's going to be fine, they're going to be hypothyroid with conflict.
That's a very sensible way forward, really, isn't it?
But the TSH point is one to educate all anaesthetists on data. It's completely ignored now. And there was a not unrecent example of the patient in another hospital, not so far from here, who was cancelled by an anaesthetist despite T4 and T3 being within range of TSH was suppressed. So what? So yeah, it's important to educate anesthetic colleagues. Should we move on? Now for something a little bit different.
I think that's one.
I want to welcome Dr. Mutar from Leicester. Thank you for coming and talking to us about difficult management decision in a patient with an aldosterone secreting adenoma.
Good morning, everyone. My name is Hader Imtiaz. I'm one of the ST5 trainees from University Hospitals of Leicester. Thank you for providing me with an opportunity to present this very interesting case of a patient with primary aldosteronism. I will start with a very brief introduction. As you would know, that primary aldosteronism is an underdiagnosed cause of hypertension. Approximately a quarter of the population of UK has got hypertension, and out of those, 5 to 15% of the patients have got primary aldosteronism. Out of the patients who've got resistant hypertension, 25% of the patients have got primary aldosteronism. 30% of the patients would present with hyperkalemia, whereas the rest of the patients would present with a normal potassium. Aldosterone to renin ratio is used as an initial screening test, but as you would know that it's affected by medications like ACE inhibitors, beta blockers, and mineralocorticoid receptor antagonists. CT, adrenal, and adrenal vein sampling is used for lateralization, although newer imaging modalities like CT PET and metomidate PET are used as alternative to adrenal vein sampling in certain patients. Management options include conservative treatment with mineralocorticoid receptor antagonists, laparoscopic adrenalectomy, and newer treatment modalities like radiofrequency ablation. Now, so we've got a 68-year-old consultant pediatric psychiatrist who was referred by the renal physician with a 30-year history of resistant hypertension associated with hypokalemia. His past medical history involved a left-sided nephrectomy for renal cancer in 2006. He also developed end-stage renal failure secondary to poorly controlled hypertension, leading to hypertensive nephropathy and renal failure, warranting a renal transplant in 2019. And at the moment, he's taking anti-graft rejection medications. So his current problems are that he's got a refractory hypertension and he's got recurrent episodes of hypokalemia. And renal physicians are rightly concerned because they want to preserve his transplanted kidney. Other medical conditions that he has include ischemic heart disease, type 2 diabetes, and obesity. He is taking 3 antihypertensives, a calcium channel blocker, an ACE inhibitor, and a beta blocker, along with anti-graft rejection medications and anti-anginas. When he was seen in the clinic, he was overweight, but he was not clinically Cushingoid. His blood pressure was 160 by 100 millimeters of mercury. He was hypokalemic with a potassium of 2.6 millimoles per liter. His EGFR was 64. His aldosterone levels were 1149 picomoles per MIU, and renin was 5.8 MIU per liter. His post-dexamethasone cortisol was 104 nanomoles per liter, but I would take these results with a pinch of salt because he was still taking prednisolone when his dexamethasone test was done. As you can see that he had recurrent episodes of hypokalemia. His potassium has barely been in the normal range, and he's had recurrent hospital admissions with low potassium and high blood pressure. So we organized a CT scan to investigate further, and as you can see that he's got a right adrenal adenoma, which is 1.3 centimeters in size and has got 13 Hansfield units, which suggests that it's lipid rich. This is a sagittal view, again showing an adrenal adenoma in the right inferior lobe of the right adrenal gland. And this is an axial view, again showing an adenoma in the inferior lobe of the right adrenal gland. Now, the surprising thing for this patient is that he had radical left-sided nephrectomy, and on CT scan, we were able to see adrenal tissue on the left side, despite having radical nephrectomy on the left. It has got an altered anatomy because of the previous nephrectomy, so it's situated quite inferiorly as compared to the right adrenal. As you can see here again in the sagittal view, left adrenal gland, distorted anatomy. This is an axial view, again, showing the left adrenal. Now, because we've got a very close working relationship with Cambridge, we were able to organize a CT PET because we wanted to investigate this patient further. Adrenal vein sampling would have been very difficult or impossible in this patient, considering that he had nephrectomy in the past. So on CT PET, you can see that there is an increased uptake of tracer in the right adrenal gland in the inferior lobe, suggesting that he's got an aldosterone secreting adrenal adenoma. You can see sagittal views, axial view, adenomas here, and then coronal views as well. So it's very important to know that this was done by using an 18F fluoroethyl etomidate, which is slightly different from etomidate because it has got a longer half-life and has got higher sensitivity for adrenal as compared to metomidate, which can be uptaken by the liver and the spleen as well. This is something that's used very easily. And on the left side, you can see that there is physiological uptake of the tracer, suggesting that he's got viable adrenal tissue on the left side as well. Now, whilst we were waiting for a definitive management plan, we started him on spironolactone 50 milligram once a day. He had excellent clinical and biochemical response. He reported that he was feeling significantly better for the first time. And as you can see that as soon as he was started on spironolactone, his potassium levels normalized and his blood pressure also normalized within 3 months. Now, to summarize the case, we've got a 68-year-old gentleman who's got a confirmed right-sided aldosterone-producing adenoma. He's got a previous radical left nephrectomy for kidney cancer. He's got a transplanted kidney for end-stage hypertensive renal disease. He's got refractory hypertension and hyperkalemia. Now, the question for the audience is, how should we manage this patient now? Should we just continue with medical management with spironolactone? Should we refer this patient for laparoscopic adrenalectomy? Or should we consider something else, for example, radiofrequency ablation, considering his comorbidities? Thank you very much.
Okay, let's do some votes in and then I'll reveal. Do you want to vote, everybody? Including those on Zoom? Are you coming in? Yeah, okay. It's in the chat. Yeah.
While we're waiting for people to vote, David and I were just discussing what the sequence of events was between him having a radical nephrectomy for cancer and receiving a transplanted kidney. What?
Yeah, so he was diagnosed with renal cancer in 2006.
Yeah.
And he underwent a nephrectomy.
Yeah.
And then subsequently, because of his poorly controlled hypertension, he developed end-stage renal failure in 2019 when he had the renal transplant.
So I'm surprised. I thought that would have been a contraindication to having a transplant of past history of cancer.
So his cancer was removed because he had an nephrectomy.
I get that.
He was
Yeah.
After 5 years, you have a transplant, you're cancer-free after 5 years.
We have a question.
yeah.
I think I'm surprised if after a radical nephrectomy, you still see a residual adrenal tissue. Because that reflects the lack of severity on the patient part and also on the location of the tumor that they went in the radical nephrectomy for. Many a time, if the tumor is not necessarily in the upper wall of the kidney, people would not be sedulous enough to move the pancreas and spleen to make sure they get every little tissue of the adrenal. And it is not uncommon for us or the radical nephrectomists to leave some residual tissue, albeit the term you will read on the operation will be radical nephrectomy.
I think you've made a very good point. We were quite surprised to find out that despite having medical nephrectomy, this is what we confirmed from the urology department, and he still had adrenal tissue on the left, which is quite surprising. We weren't.
When I mean it was not uncommon.
Oh, is it common?
Yeah. Because it depends where the tumor was. Many a time, if there is a large lower pole tumor, we would sometimes deliberately not disturb the adrenal on that side, although it makes the operation much more difficult
Then what did you do?
So we just started him on spironolactone.
I'm going to go back to the
He's had a good response to spironolactone, and it's the next step would depend on whether he's definitely got like functioning adrenal tissue on the left. Because if you consider surgery, we would want to make sure that he's got functioning adrenal on the left side. And the other possible option is radiofrequency ablation, but I would leave the management option open to see what the experts think.
We'll take microphones to Brian Burnick, and they have an opinion on what can be done in these situations as far as alternative treatments is concerned.
Thank you. No, I would agree with you, and we discussed that. So if there's got a good response to spironolactone, then it's the most tempting option. But yes, on the left, you could consider radiofrequency ablation. It's a paid procedure, done endoscopically. We don't need general anesthetic, but it's still part of the clinical trial at the moment. It's not standard care. Yes.
Yeah, he's our case. I mean, I spoke to him on the phone a couple. He's a really nice guy. Paediatric psychiatrist is a colleague, friend. He had a pulmonary embolus a few days ago, so he's definitely not going for surgery for now. And what we've decided, he's doing so well on spironolactone that he was actually submitted to the WAVE study to see if he would be a candidate for trial, but because it's so messy with everything he's had, he's not a good candidate for a trial. But when the clinical experience increases over the next couple of years, we probably will be thinking about radiofrequency ablation as we get more data out. So we're going to go for spironolactone and then maybe in a couple of years radiofrequency ablation.
As a surgeon, I would not operate, but I would say there's another option, and that's a subtotal adrenalectomy. And don't worry about what the left is doing at all.
Yeah, I mean, the issue here is can preserve cost and function with the operation. That's, I think, the RFA has that potential advantage. But as David said, in some parts of the world, columns is treated routinely with a partial adrenalectomy.
Just one question on here, Miles, which is what does Aspire and what does currently happen?
What's that? 50 milligrams, and within thoracic actually, and his test was 4.5, so that was within about a week. And he's been feeling rubbish for years, probably with his hypokalemia. It's quite surprising actually how late that diagnosis was made, because he's been under the renal position for a few years, had a renal transplant, as you said, with previous year cancer, it's not a perfect candidate. And then actually a guy who was RSHO, consultants, Miles, could this be eyebrow steering? It's unusual to have hypokalemia in a renal clinic, normally hypokalemia. So I think it was quite a late diagnosis, I have to say.
Thank you.